Good morning, everybody. It's great to see you and so glad to have you. Welcome to our fall virtual Hill briefing, where we have an amazing lineup of speakers for us today. And we've got pretty tight schedules, so we're gonna go ahead and jump right in and get started. We're gonna kick off with some announcements from David Gray at HIMSS, and then we're really excited to hear from Congressman Burgess, and then we have a fantastic distinguished panel with whom I will have the honor of moderating and introducing you to. So without further ado, I'm going to go ahead and pass it over to David.
Hi, morning, everyone. I'm David Gray, Director of Government Relations with HIMSS and one of the co-chairs of the Match Coalition. I'm very excited for today's session. We've got a great welcome video from Dr. Burgess and a fantastic panel. But before we jump in, just a few quick announcements. I'm excited to share that today's Match Coalition event is sort of a sneak peek for the HIMSS 2023 Global Health Equity Week, which officially kicks off next week. Global Health Equity Week is an initiative focused on displaying the potential of health information technology to transform health, support the elimination of disparities, and improve access to healthcare for all communities. HIMSS and our chapters and our partner organizations have a number of virtual and in-person events and education sessions throughout the week. We have a number of interviews lined up and sort of resources being put out on a range of health equity issues. Maternal health has been one of our top focuses for the last couple of years, so we're very excited about that. And there's more information on all of the events on the HIMSS website, hims.org. Secondly, in support of Global Health Equity Week, HIMSS and the Match Coalition are going to be officially launching a grassroots advocacy campaign in support of the Black Maternal Health Omnibus Act. This is a bicameral bill that we've long supported. And we're also going to be supporting two standalone bills from the Omnibus Act. The bipartisan Tech to Save Moms Act, which supports the use of telehealth and technology to improve maternal health. And the Data to Save Moms Act, which supports improvements to maternal health data collection processes, as well as promotes greater diversity and community engagement in maternal mortality review committees, the topic of today's discussion. So we'll be launching that campaign, sharing it, promoting it, starting next week. It really just takes a few minutes and a few clicks to reach out to your elected officials and tell them to support these bills and urge Congress to sign them into laws. So that's that. If anyone has any other events or updates that they'd like to share for this group, we strongly encourage you to put them in the chat. So with that, I am pleased to kickstart this event with a message from Congressman Michael Burgess. Dr. Burgess represents Texas's 26th district and is a senior member of the House Energy and Commerce Committee. Dr. Burgess practiced medicine as an OBGYN for nearly 3 decades and has championed many maternal and infant health bills throughout his time in Congress, including the Connected Mom Act, the Preventing Maternal Deaths Reauthorization Act, which Congress is debating right now, the Maternal Health Quality Improvement Act, which was signed into law last Congress, as well as Maternal and Child Health Stillborn Prevention Act of 2023, and a number of other bills. He wasn't able to join us in person, but him and his staff have shared a video. So let me share that with you all now.
Hello, I'm Congressman Michael Burgess. I'm grateful that both the Healthcare Information and Management Systems Society and the Match Coalition are here to kick off this critical discussion on the maternal mortality review committees. This briefing comes at a pivotal moment in our ongoing efforts to combat maternal mortality. Maternal mortality review committees are the backbone of our strategy to address the rising maternal mortality rates in the United States. These committees play a vital role in understanding the root causes of maternal deaths and preventing future deaths. Every maternal death is a tragedy, not only for the mother, but for her family, her community, her caregivers, and our nation. It's a heartbreaking reality that we can and must change. Even one death is too many. The Preventing Maternal Health Deaths Reauthorization Act is a critical piece of bipartisan legislation. It takes a significant step towards addressing the maternal mortality crisis. This legislation supports maternal mortality review committees by providing them with the resources that they need to conduct a thorough review, collect meaningful data, and disseminate their findings effectively. The Senate has already considered this legislation in committee, and now we need to ensure that it becomes law. The health and well-being of mothers across the country depend on it. We can't afford to let this opportunity slip away. Today, you will delve into the operational mechanisms, the review processes, the data utilization, findings dissemination, and the crucial engagement with stakeholders. By reviewing these aspects, we can identify the strengths and areas for improvement in our collective efforts. I am confident that you have an outstanding lineup of experts and professionals who will share their knowledge and insights. I encourage you to actively participate, ask questions, and engage in the conversation. Together, we can make real progress in the fight against maternal mortality. Thank you for your work to ensure that no mother's life is cut short and that every child can grow up with their mother by their side.
Thank you to Dr. Burgess and his staff for facilitating that video and for being a champion of a number of bills that the Match Coalition is advocating for. So, Fran, that I'll turn it back to you.
It's so great to see everyone, and thank you, David, and thank you, Congressman Burgess, for that wonderful opening remark regarding the maternal mortality and morbidity review committees. We're looking forward to today's panel. As you may have noted, the title for today's panel is centered around unveiling really the whole inner workings of the maternal mortality review committees. And we thought this would be an appropriate time to really introduce this because we hear more and more about MMRCs, but not everybody really knows what they do. So we thought we would bring together, quite frankly, some of the nation's most distinguished subject matter experts on this particular topic. So we're very pleased and honored to be able to introduce you to Dr. Joya Criar-Perry, Robin Dioria, Dr. Kim Gregory, Melissa Lemon-Fledger, and Santosha Pratt. I believe Ms. Pratt may not be able to join us today. We are sympathetic. She's had a bit of a cold. As many of you know, in many parts of the region, there's a bug going around. So she said that she might be able to jump in. So we'll keep our fingers crossed that she will be able to participate. But in her absence, we certainly will make sure that her sentiments regarding the community's view on this topic are represented by other members who are participating in today's program. So without further ado, I'm going to allow for each of our panelists to be able to introduce themselves, along with kicking us off with the very first question that we have posed for today. And that is to really, along with sharing with us your roles and responsibilities, talk to us a little bit about the overall functioning within the context of maternal health, how your MMRCs are structured and what the framework and sort of operational dynamics are. And let's all together kind of look at some of the similarities as well as some of the differences based on each of the panelists' experiences. So to get us started, I'll hand it over to Robin Dioria from the state of New Jersey.
Thank you so much, Fran, and good morning, everybody. It's a pleasure, and I feel a privilege to be here with my esteemed colleagues. I am actually a nurse. I'm an advanced practice nurse, a perinatal clinical nurse specialist, and currently am the CEO of Central Jersey Family Health Consortium, which is a not-for-profit in New Jersey that does maternal child health, public health type initiatives in our state. We have had the good fortune to coordinate the maternal mortality review team in our state since 2002, which is when I actually joined the maternal mortality review team. Prior to that, I worked as an abstractor on a consulting basis for the program. Maternal mortality review has a long history in New Jersey. We were fortunate enough, and actually are the second longest running maternal mortality review team in the country. Started back in 1932 and actually was run out of the New Jersey Medical Society up until 1999, when the New Jersey Department of Health took over the program. The consortium, the organization that I work with at that time, then coordinated the program and ran the program in partnership with our Department of Health. The program was funded by the Department of Health for years, but it was in 1999 where we actually legislated in the state of New Jersey for the MMRC to exist. And with that legislation, it allowed us to really codify the MMRC, the membership, the roles, and what would be done. And we felt very strongly that that would help us not only ensure that we could maintain the MMRC for years to come, but also to put some grit behind the recommendations that came out of the committee. And it would allow us to as well prioritize what was felt by the committee to be those leading issues that could address morbidity and mortality in our state. So that is the way we stand now. It is a 24-member team. The team, there are actually different roles. Many of the professional associations that are involved with maternal health are involved, such as ACOG, AWAN, Society for Maternal Fetal Medicine, but also emergency room physicians, family practice physicians, anyone that is really involved with women's health care. In addition to that, there are other stakeholders that were identified, including faith-based, community-based agencies, and looking to have the consumer perspective as well and the community perspective, because we realize how integral that is. The appointments are made through an application process that are then approved through either the governor's or the governor's office or the commissioner of health's office. And the term is then set should it's a voluntary position. We meet at a minimum quarterly, but as we try to get to the closer time frame that the CDC would like cases reviewed within a 2-year period, we actually are meeting monthly at this point in time, which really speaks to the dedication, I must say.
It sounds as though it certainly does. And we're going to dive even further into that. And I really thank you for putting together the sort of the structure and how you bring about that diversity in terms of stakeholders who are represented. We've got three more to go through. So you guys bear with me here as I transition over and have Dr. Gregory describe her experiences working with the MMRC California. And thank you, Ms. Dioria.
Well, I can capitalize on a lot of that because there are some similarities. I'm Kimberly Gregory, and I'm honored to be here today. I am I'm vice chair for Women's Healthcare Quality and Performance Improvement at Cedars-Sinai Medical Center. I'm a practicing maternal fetal medicine subspecialist, and I've been part of the California Maternal Mortality Review Committee since it started back in 2006. As a team member, and I just recently got the honor of being named the chair for the state of California and their review committee. So I'm speaking sort of from that position today, and just say to capitalize on what Robin has already talked about. We've been in existence since 2006, funded through the California Department of Public Health and their partners, the Public Health Institute and the California Maternal Quality Care Collaborative. And that actually helps us put our data and recommendations into action. And so it's been a very effective tripartite, I guess I want to say. A current committee we actually are organized into two to three active committees, depending on what's going on. We have a standing perinatal pregnancy mortality surveillance system, which reviews all pregnancy-related deaths, determine if they're pregnancy-related, and it keeps us current so that we're doing sort of active surveillance. Based on that, we then decide if we're going to do more targeted reviews, and then those targeted reviews go to the Pregnancy-Related Mortality Review Committee, which is our functional MMRC, and then that will do a very focused, in-depth analysis, and we come up with recommendations, and those recommendations ultimately have ended in the toolkits that are popularized across the country. Not just ours, that obviously the AIM bundles, which are very similar. And then we also sometimes do even more focused rapid reviews. So for example, we just finished after showing a decline in hemorrhage deaths. We actually did another focused review of all hemorrhage deaths to see if there's even more improvement that we can do. And those recommendations will be coming out soon. We've done a review of suicides. So we've done very targeted reviews on different things. Our current targeted review committee is related to all the COVID deaths. We're reviewing those.
Very fascinating. Thank you so much for that introduction and giving us a little bit of a glimpse into how your committee is structured. Let's take a look at the state of Michigan, and we'll have for Melissa Leon Flicker to introduce yourself, please, and tell us a little bit about the structure of your MMRC.
Thank you, Fran. And again, it's an honor to be a part of this panel and to be with you all, joining you all in conversation today. My name is Melissa Lamone Flickler. I'm the coordinator with Michigan's Maternal Mortality Surveillance Program. We are a state-level structured program housed at the Michigan Department of Health and Human Services. Very similar to what you just heard from the other two states. We review cases of maternal death, and our scope of review is all maternal deaths that occur within 1 year of the end of pregnancy. So that includes your medical, what you would consider more of your hemorrhage, hypertension, infection-related deaths, but we also review deaths due to homicide, suicide, and substance use, as well as motor vehicle accidents. So once we work in partnership with Vital Records to obtain birth and death files, and with each birth and death file we receive, I begin the process of requesting records for each maternal death case. And the records that we request span their medical and non-medical records that we're requesting. So we're inpatient, outpatient, but we also request behavioral health, WIC, maternal infant health, home visiting records, and Medicaid, just to get a better understanding of each mom's life course. All that information is collected, abstracted, de-identified, and then it's presented to a maternal mortality review committee that is also multidisciplinary in nature. And then upon hearing the case, which is being presented, the committee then identifies contributing or risk factors and then recommendations aligned to those factors that were identified during discussion. And those recommendations form the basis for our guide prevention initiatives in Michigan. So that's just a snapshot of what we're doing in Michigan.
That's fantastic. Thank you so much. It's a lot that you guys are doing in Michigan, and I know that there is a lot going on in Louisiana as well. Although I have to confess, for Dr. Creapierre, everyone, of course, knows that you have both not only some state representation, but national and global representation and influence as well. So I appreciate that you were able to bring all three of those, a trifecta, if you will, into your perspective on this topic, and we welcome your remarks. And if you could maybe first share us a light. We know that Louisiana is home. So we'd love for you to give a little bit of a shout out to some of what you know and are familiar with from your long experience within the state, but equally shed a light on some of what then you have seen more broadly in terms of MMRCs across the country.
Thank you so much, Fran. And really, I was excited to see Congressman Burgess as my fellow OBGYN. It was 5 years ago that I was the Democratic witness for the original bill that we're now fighting to get refunded. And that bill, and Robin and I used to be in all these meetings in Kim and talking about how we need to actually count maternal deaths, because we know from 2009 to 2017, the United States did not release an official count for maternal deaths. So this bill is so important. So what we get to do at a national level is really advocate and ensure that these states are able to get the funding that they need so that they can continue to do this amazing work. All the things that we're talking about right now that the three of my colleagues have spoken about would not have been able to be done without this investment through the federal government to the CDC for the Preventing Maternal Deaths Act. So that's one of the things that we get to do as an organization and see how the interplay works. And locally, the person who's 5 years ago, I was participating on the Louisiana MMRC, and so I could have told you a lot more information. But the person who is over it is Dr. Veronica Gillespie, and I texted her because I wanted to make sure that Louisiana got the right more verbiage for what they're doing. So she writes me back that our MMRC is diverse in knowledge, race, ethnicity, and background, half being clinical and half being non-clinical, and they do include patients, including those who are patients who have substance abuse specialists as well. So really, we weren't able to get this level of that. We would say things like between 700 and 900 women a year die. That was kind of our all standard talking point. And although that sounds like a normal thing to say, we knew exactly how many babies died each year. So the same time we would say 700 to 900 as a range for women, for birthing people, for people who have the capacity for pregnancy. For babies, we would say 23,252. And that just shows you that we were not valuing women. We were not valuing mothers. We were not investing in the information that these amazing folks are talking about now. So really the importance of being able to now we have actual exact numbers because of the work that they are doing at their sites. We were also able to add racism as a risk factor through the Maria system, which is really important. And as we move forward, and when I say we, I mean MBEC, was a part of a committee that had Dr. Kamara Jones and Rachel Hardiman and others to really help and support the CDC with defining what racism is so that these committees could really work to ensure that we undo the harms of racism, classism, and gender oppression, which is causing our maternal mortality crisis in this country. So that's it.
That's a great overview. Thank you so much for that. And we really appreciate Dr. Veronica Gillespie Bell for providing those additional notes. As everyone may recall, she, along with Senator Cassidy, were amongst the first to present here at the Match Coalition. And they're certainly doing a lot of work as it pertains to leveraging technology and remote monitoring of women to ensure their safety and better management of elevated or gestational hypertension and preeclampsia during pregnancy. So thank you, Joya, for bringing that to the discussion, and to all of you for giving that beautiful overview of what's going on in your states. I just want, as a reminder, encourage everyone to put questions into the chat window. You know, we always like to make time towards the end for everyone to participate in the dialogue, but certainly if you have a burning question now, as you hear each of our panelists, please go ahead and make those remarks. And as you're doing that, I want to step back for a moment, because actually I heard from each one of you reference a variety of different types of data that you're actually bringing to the center of the discussions that you're having as part of your MMRCs. And I would just be curious to have you to expound upon that a little bit more. For example, there was a reference to behavioral information and substance abuse and other perhaps social determinant factors that are being incorporated. Or maybe there's some that you'd like to see that aren't quite being incorporated the way that you would anticipate. Can you elaborate upon that a little bit more for us? And maybe we'll kick it off with Robin. But as everybody knows, I don't like to have to do shout outs to get everybody to talk. So I'd like for you guys to just jump right in on and follow on from Robin, if you would, please. But Robin, if you'll get us started, that'll be great.
So I will start, and some will be repetitive, but I do want to give a shout out to Melissa, because she names some different areas of data that they're able to access that we aren't in New Jersey. And I think it's important to point out that access to data isn't necessarily equal across the states, across the nation. And what we can access today is very different than what we had access to 20 years ago. And I can attest to that. Besides the patient records, we'll look at other pieces of information. We were thrilled when all of a sudden we were able to access, not all of a sudden, but after multiple attempts, emergency EMT records to get a sense of the transport and what happened on transport. We, looking at the RIME, or the routine investigation of the medical examiner, yields huge amounts of information, particularly information about families. Now that we're doing informant interviews, that provides more than anything that you can get from a chart. And it's a different perspective. When you look at the clinical records, the types of records that we routinely looked at, the hospital, physician office, prenatal record, that's one thing, but hearing the voice of the family, which very often is the voice of the person who has passed, can be so incredibly enlightening, informative, that will help us with recommendations to make changes, in whether it be in systems or otherwise. So it does make a difference. And the last thing I would say is the use of a standardized tool. So the advent of Maria back in, we started, it was only in mid-2010s that even came to fruition and started to use it. It has made such a difference to standardize from state to state, but has also expanded what we routinely look at. And I think it's very important for us to keep that in mind. But some of these other records, whether it be substance use, mental health, providers still are challenging for many states. And if there's someone who has their case being in legal review, that also is another huge barrier for us. I could go on, but I pass the baton.
Yeah, I just want to hop in before, because I want to first read Veronica's and then just say that, to Robin's point, there's a huge, we are advancing greatly, right? We couldn't get any, like when we started this, even just in 2017, people were physically having to go into and only having access to hospital records. There weren't a lot of folks who were getting any other kind of records, wraparound records. And so we were making decisions without complete understanding, and then moving to being able to actually interview people. That also requires money. The hospital has to take the charts, has to go and visit. So a person couldn't exist could do that. If you're asking a hospital or a state to do all these extra things without funding to do those things, then you're adding a burden to states that they cannot meet that burden. So that's why the importance of this bill is just so critical. So I just want to say, once again, this is a Hill briefing. So we need the Hill to understand the importance of funding this work, because states cannot do this work without having funding. But what Veronica wrote is, we rely on medical records, police reports, obituaries, and in 2024, they will start having informant interviews, which was talked about, right? So if you don't know why a person showed up at the hospital who didn't have prenatal care or not, you make assumptions about why they did not have care. We can think about Tori Bowie. We have all these questions about how she died at home as an Olympic athlete. Someone has to actually ask the people who were around her what happened. We can assume there's a bunch of news articles making a bunch of assumptions about who she is and what she was. But until we ask why a person who won a gold medal died at home and her baby died, we will all be making assumptions. So that is the importance of why this funding is so critical. So that's it.
Yeah, Joy, I appreciate that. In California, we use all of the records that everyone has talked about, the linked records, the autopsy reports, the ER records, as well as the EMT records. We even get the anesthesiology reports. Those are kind of important. And we also use the Healthy Person Index, Healthy Places Index, HPI, which is a measure of the community and the access and the basically how privileged the community is. And if you're in the first quartile, you have more resources versus the fourth quartile, which is obviously a poorer neighborhood. And we have found that that's down to the level of the census tract, and it's definitely correlated with maternal mortality.
Great, and we are very similar to some of the records that already have been mentioned. In addition, we are requesting as I had mentioned, home visiting records, which with home visiting, we obtain risk identifier reports, which talk about things, for example, like prevalence of intimate partner violence and what the linkage is to resources. So we find those really valuable in painting that the picture, because we're collecting all these records, which help put the puzzle together of her life course and her story. We want to make sure we're doing her justice when we're presenting her case to a maternal mortality review team for deliberations, because we know that after hearing the story, these recommendations, which are so rich and can be impactful, especially around funding and policy change, they're a result of the data that's collected for each case. I also wanted to uplift what Robin and Dr. Joya Perry mentioned about family interviews. I also want to uplift the grief and bereavement, the need for grief and bereavement resources for families. We know with one family that our interviewer had interacted with, there aren't a lot of resources geared towards the surviving parent, the grandparent who might be caring for the family, and also for surviving children who have lost their mom.
Melissa, thank you for that, because you're so right. And I think the other briefing request for money is training and at the pathology level. Like, first of all, it's amazing that not all maternal deaths even get a path report or a coroner's report. And then when they do, sometimes it would be more beneficial if more information was provided. So if there was a standard of what could and should be done. And again, that requires money, and it also requires it becoming important among that specialty. So that would be something that we frequently wish, like, why didn't they get a path report? Or I wish this path report gave us more information.
I just want to channel my friend, Dr. Roger Mitchell, who is a board certified pathologist, who talks about how coroners are not the same thing. If you think about the state of Louisiana, the coroner in my city of New Orleans was an OBGYN like me. So for decades, the person who was in charge of the pathology report was the person who has the same level of clinical information that I have. And I should not be anybody's medical examiner because I don't know anything about how to do any of those things. So really reimagining and thinking about who is in charge and how we decide who is making these decisions about the causes of death. So that's a real structural problem, that we have folks who are elected to office as coroners who don't even need a medical degree. And you are then creating you're having expectations about who gets an autopsy or not, when most of the people across the country are coroners, the word that you use, then are not board certified pathologists, as Dr. Roger Mitchell, who is now the chair of pathology at Howard University, would like to point out. So we need to know the distinction between a coroner and a board certified pathologist.
Thank you for that.
I just got chills over here, because that's like you have just shine a light on a real dark hole in the system. Wow, thank you for pointing to that, and that everybody's head is nodding is an indication that it's a national dilemma, but seems like one that could be easily rectified, right? I'm going to turn now to a couple of comments and questions that were in the chat, because clearly this topic of data being leveraged is a big one. You guys keep seeing my eyes go up and down because I'm reading through all of these chats, and there's the first one that comes up that's in relation to ensuring that we're capturing prior complicated pregnancy and complicated pregnancy, so history of complications during pregnancy and chronic health indicators such as hypertension, diabetes, et cetera, to connect those with the deaths. And to go along with that, Dr. Miriam Modestin from New Jersey comments, how do we account for these contributing roles of such conditions as overweight and obesity, which are key indicators to cardiovascular disease, which is, of course, as we know, one of the leading causes of death and morbidities. Anyone care to comment on those two posed questions?
Just because I'm old, I want to go first so I don't forget what my answer was going to be. Just that we've seen that although there is a high rate of obesity, the rate of correlation is questionable. That we have recognized that when we disaggregate data by race and by ethnicity, by age and by income and by weight, even, that Black women who are normal weight are more likely to die than their white counterparts who are obese. So although we spend a lot of time telling people how they need to lose weight, and although it's very difficult on us as providers and it does increase your risk of hypertension and diabetes, if our only focus is to focus on weight and we don't deal with the structures that cause harm, like domestic violence that we talked about, or like not having access to the materials we need for hypertension and diabetes when the person gets there. We know that Black patients get to the hospital and they're less likely to have their hypertension even treated. There's a lot of studies from UNC. There's an amazing study that showed that we are less likely to have our hypertension treated because people perceive that we always have high blood pressure because we're always making bad choices. And so then we're more likely to have a seizure or a stroke or heart attack. So we are working to undo the biases and work on respectful maternity care that understands that the underlying root causes are not to only problematize moms and their behaviors. So I just want to say that. So I'm sure the other medical folks will say other things, but I just want to make sure that people understand focusing on obesity we did that for decades and it did not solve anything in this country.
So I'll comment a little bit more on Kim's question about capturing prior complicated pregnancies. To be honest, that has not really been part, unless it's been captured on the prenatal record of the pregnancy that resulted in the pregnancy that's associated with the death of the person. And the reason, frankly, capturing any prior information, even having a prenatal record, sometimes you don't even have that when you are doing the abstraction. And that is a problem. And, you know, if I lived in the perfect world of data and health information, and we had a chart that started from infancy through adulthood, and it was all in one place where I didn't have to pull it from all these different and put together the pieces of this puzzle, then I'd say yes. But what I will say is, the answer is no. We probably don't have access to that data. But what I will say is that the information that we garner from the abstraction and from the case review influences policy, as well as provides the recommendations for programming and other types of initiatives that hopefully will prevent a similar outcome for others. So that the complicated pregnancies, the chronic health conditions, the hypertension, the cardiomyopathy, particularly in the cardiovascular realm, which is where we've seen this increase, the late maternal deaths that we see that are often related to cardiovascular conditions. It's that information now that will influence future pregnancies.
So I'll dovetail into that. And again, acknowledging that we're briefing the Hill. For those states that have bought into the 12 months postpartum pay for ongoing care, this is our opportunity to do something about some of those chronic diseases and decrease the likelihood of subsequent cardiovascular disease. And a shout out to the American Cardiology Association, who is actually trying to evolve a specialty of cardio-obstetrics so that we can capture that. One of the new, not new, but one of the things that they're encouraging family practice and internists and cardiologists to pay attention to is the obstetric history. Did you have a history of IUGR? Did you have a history of preeclampsia? Did you have a history of diabetes? Because those are things that put you at increased risk for cardiovascular disease. And we have this great opportunity to actually do some prevention, because we've screened for these women. They've identified that they have a problem, and yet we wait for them to develop the disease 10 or 15 years later. So if you haven't, if you're a state that hasn't bought into that, this is a great time to go back to your legislatures and ask them to vote for ongoing care, to extend it from the normal 6 weeks to the full 12 months postpartum. And then I just want to use my own personal opinion to echo the request for a unique medical record number that follows you throughout life. There are some European countries that do it, like Denmark, and where we actually are, if we really want to know some longitudinal information, we always go to that database to find out what happens. But I think that it would be great if America could come up with a pregnancy registry and or a unique medical record number that follows you throughout your life.
Mm.
And I really don't have much to add. Everything I was going to say has already been mentioned. I will uplift health literacy. I know when we are working and doing some community work, health literacy and knowledge. So we can talk about these terms, but it might not be something that's familiar to the patient themselves. And maybe in the 15-minute visit that they have, they might not feel encouraged to ask. And so I just want to uplift that and add that to the conversation as well.
And just
I have
Fran,
to say, you have given me goosebumps. I'm getting goosebumps all over this conference. Like, you guys are just like, it's just shivers going down my spine, because everything you're saying is just resonates so much with what, from when I put my community epi hat on. Right, these are sort of at the, in my opinion, sort of the essence of things that we need to tackle. And Kim, when you made that remark regarding the 12 months, the 12-month extension, this is something very early on when some of the states were adopting it that I paused and I wondered, like, okay, great. So we're going to do 12 months. What's going to be different? What are we going to bring forth in those 12 months? Because if we just get all of what we've seen in 6 weeks, we're not going to be making much progress. So I love how you've carved out an opportunity for prevention and opportunity for health literacy and many of the other critical points that you all as a panel has brought forth on that topic. Huge ones. Someone else on the chat says, what about the MTSV rate? And what do we do to determine what's a safe NTSV rate? Anyone care to comment on that? Yes, please, Joya.
I just want to say, David mentioned the Momnibus in the opening, and that in the Momnibus, there's funding for data to make sure that we can get data from the community to pay for, and there's a group, We Must Count. People have looked into how we can extract health information from our medical records and get it to the provider. So we have an opportunity to fix all this, y'all. We really do. We just have to pass these bills. So that's all I want to say. NTSV is probably Kim's thing, because I know it's a California thing.
Let's say that that's probably not the most critical part of the maternal morbidity. And well, it is part of maternal morbidity. It's probably not a significant part of maternal mortality, although it is true that if you have a C-section, you're at increased risk of having a maternal mortality. I don't know that there's an ideal rate, but I do know that a lower rate is better and that we could be better getting to lower rates. That's probably the most diplomatic that I can be right now.
Mm-hmm. Robin, do you care to comment on that from New Jersey's perspective? I know they're sort of opposing views on these points, but they're really important ones.
I would probably echo Kim's comment. And I think avoiding surgery, if at all possible, is definitely the preferred methodology for delivering, for especially thinking subsequent pregnancies, etc. And untoward complications that can occur from a C-section that may have nothing to do with the pregnancy, but may happen. And we've seen cases like this. So it really is important to weigh the pros and cons and determine what is the safest for that person at the given time of delivery. And I would agree, lower is better. And we've seen decreasing rates of first-time cesareans. I know for us in New Jersey, using the AIM bundle and implementing that within our hospitals, and I've seen that in other states where rates have come down. But a C-section at times may be the best answer for both mom and her baby. So it's tough to say what's that perfect number.
So is this an example of a long-standing debate? And I'm going to take this. Okay, because I'm going to take this.
I was going to try to add Louisiana, because I so try to talk about why we're all kind of talking kind of a little odd, and y'all are like, what are they talking about? So what we do is we pick a thing to focus on. And so NTSV was the thing we focused on for a while, and we didn't see magical change. Just like Medicaid extension is exciting. And yet, even in the states that do that, if you come back to us and say, did that fix all of maternal mortality? We're going to say, well, clearly not. This one thing won't fix everything. So part of what you're hearing us do is equivocate about the fact that there was a time that it was the California strategy, it was the whatever strategy. So when we come back and look at the data, we can't say that one strategy actually did. So in Louisiana, what we did, it worked great for a while. It still works. Physically, what you do is just have accountability. So across the state of Louisiana, people were doing primary C-sections on people and no one was paying attention. So when you created a person like Robin, whose job at the hospital was to say, listen, doc, you can't just do this C-section. I'm in charge. And if you want to do this C-section, there's a group of us who are going to look and hold you accountable. This is, I know this might sound like this happens, but it does not happen. So because part of the toolkit made people have to like explain to a human being why they wanted to perform a C-section, it made accountability in the system that doesn't currently exist. So we can't, so this idea of giving you a certain number, when we have folks who had never had any accountability to finally have some accountability, that's where we are. We're like, look, we're going from people who've never had anybody question their medical decision-making to now we're saying to them, there is an account, somebody's looking at you, somebody's paying attention, they're gonna look at your numbers and they're gonna call you out. So that does help. That will not solve the maternal mortality crisis by itself.
Okay, well, we're going to come into a section where folks will get an opportunity to come onto camera and ask questions. So we'll just hold off for 1 second. I have one more to bring to the panel. And then I promise you guys, we're going to open it up to everyone and have that opportunity to dialogue. For just a moment, though, of pause, you know, we think about the delays, right? The 4 key delays. Delays in seeking care, delays in transportation, delays in diagnosis, and add to that misdiagnosis, and then delays in treatment. Those are sort of our 4 areas. Broadly speaking, we know those are the things that can create for the prevention. But how is this surfacing in the context of your review committees and the changes that you're mandating? What are some of the, like, can you give us examples of some significant findings? And maybe if we have a win of where those significant findings have resulted not only in institutional change, but maybe statewide change or national change in the way that care is being delivered?
I'll take that as like the first, like, think of hypertension. Like, you walk in the door and your blood pressure's up, and historically people would say, oh, you just have chronic hypertension, you have high blood pressure. And even, you know, not just culturally, but nationally, people will tolerate high blood pressures as, you know, not a big deal. But in pregnant women or recently postpartum women, a high blood pressure is dangerous and it could lead to stroke. And so when we started seeing that, you know, this woman had a high blood pressure in clinic and then came in 2 weeks later and seized and died, we could say if they had treated that blood pressure 2 weeks ago, it could have made a difference. And so now the standard of care is to lower the blood pressure within an hour. And we've said lower it in 30 minutes. So we for sure lower it in an hour. Okay. That's a standard. So every woman who comes in our hospital or comes into a clinic and has an elevated blood pressure, if you make that the standard of care, there's no delay. There's no thinking. There's no implicit bias. There's no, this is your blood pressure high because you're Black and your blood pressure is always high. Everybody who is pregnant is supposed to have their blood pressure lowered within 30 minutes. And so suddenly the rate of death for preeclampsia and stroke has gone down. So that's how you've taken evidence and data and made a recommendation and see an impact.
I was going to read the Veronica statement just so I can make sure I get it because it's beautiful. So they evaluate social determinants of health. They create a geospatial dashboard for each descendant to look at factors such as OBGYN providers, mental health care providers, midwives. And then they look at the US, the parish of the residents. So we have parishes instead of counties versus the states versus the US. And they look at the ALICE score and other factors to evaluate for poverty and access. They also evaluate bias and discrimination through a tool they adopted from Texas called the LABORS tool, and Louisiana bias or racism and discrimination tool, where they have their abstractors to look for specific things in the medical records, such as leaving against medical advice, if the care is inconsistent, and what best practices and stigmatizing language was used. And the bulk of their review, and this is why I was really excited, because they've actually been able to use these things through the Perinatal Quality Collaborative to create policy changes in Louisiana Medicaid. So going from what Kimberly just said about having a patient and thinking about the hypertension and these policies on a hospital level, how you can actually change your state Medicaid policies to meet the things that you find out. So that's it.
I love that. Absolutely love it. Robin, did you want to make a quick comment before I open it to the floor?
The only thing I would add, and it kind of, I'll tie it up, is there are the dollars that have been provided through the federal funding have made an enormous difference in our states. Now, I can speak specifically for New Jersey. The Erase MM funding has allowed our maternal mortality review team to expand, to hire additional staff at the state level through our Department of Health and MCH EPI, among other folks, that can really help take what's done at the committee level and then transfer it. It's also allowed us to share the results and create an infrastructure within the state. We have a maternal care quality collaborative as well. We have funding through CDC for a perinatal quality collaborative to then in turn carry out many of the recommendations which Joy had just mentioned that Louisiana's doing. And it also got the attention of the First Lady of our state, Tammy Murphy, who then took this, made it her platform, developed a strategic plan called Nurture New Jersey, and all of our programs, initiatives are being housed under this umbrella, if you will, where additional dollars are being put towards these programs. And that, without the federal funding and those initiatives, this wouldn't happen. And that's how critical it is, because not one thing, not one AIM bundle, not one initiative will make the difference. We have to hit this in so many different ways before we will be able to see a decrease in morbidity and mortality.
I love that.
I do want to brag, though, that you can actually look at the implementation of some of the toolkits in California and see that there was a decline.
Absolutely.
And while the country is going up, California pre-COVID was definitely going down. So
That's very valid. It does work, and a very valid points that you have drawn out there. I wanted to at least allow for one or two super quick questions from those who are attending today before I pass it over to Elizabeth. We're getting so close to time here. So if maybe one, possibly two super quick questions. Does anyone have a question that they'd like to raise for our panelists?
And Fran, I would encourage continuing with the questions because this is a really fascinating conversation, and I'd rather hear new information than summarize what we've heard.
Okay, very good. Thank you for that, Elizabeth. Any questions from any of our attendees? You know, one of the points that had been brought up where there were a lot of tools, as particularly Joy, you had mentioned quite a few tools that Louisiana was utilizing, and I'm curious to know the value that everyone on the panel might see potentially in having the opportunity to have more data mining conducted. You know, there are stories to be told in through our history, right? And there's a lot of rich, we always say about we need more data, but we have a lot of rich data, terabytes, petabytes, in fact, petabytes of data that exists that we're currently not utilizing, for which we could have tremendous stories and certainly lessons learned from. Are any of you aware of those types of activities happening in your state, or would you care to comment on perhaps your vision of what might be possible if you had access to the variety of data that you're already sitting on, the mound of, if you knew there was this gold, as there's a gold mine of data that does actually exist, what might you do with it? And then after that, Carrie, we'll go to your question.
Great. So the Earth app, I just wanted, so there's also other ways to get data. So data from within the already in our medical records that we don't get. So when we created EMRs, as physicians, we thought that we would have access to it. But right now, if you think about it, when I'm old enough to have had a debit card that I used to have to ride around town and find a ATM machine that matched my card, right? If I go to other countries that wouldn't have it. At some point, the government said, this is too difficult. Y'all are making things too burdensome for consumers. And so they made ATM machines talk to each other. So now I can take my Wells Fargo card and go to Jamaica and get money. We have not done that when it comes to EMR. So we have a bunch of companies who are selling all of us, if you're a little mom and pop shop organization versus, or if you're Cedars-Sinai, we're all paying for electronic medical records that don't speak to each other because we have not required them to have to do that. So my fantasy world that I think is really possible is that the same way we made banks have to share information, we can make this information about our medical records have to be able to be shareable, because it is not honestly that difficult. Tech people know that already. And then I just want to plug Dr. Burgess's need, or Congressman Burgess's, around technology, the apps. So the Earth app is Kimberly Seals-Allers. It's an amazing app. It's like a Yelp for hospitals, and it allows patients to put in their information and then have it tied to the MMRCs or whatever way that people want to get that information as well.
Thank you for doing that shout out. There's so many amazing companies: Pacify Health, Baby Scripts, Happy Mama. There's and least we forget, we have with us, I think Wanda is with us here today as well with the Believe Her app. There's so many, and those whose names I haven't given a shout out to, we love you. We just don't have time to give shout outs to everyone, but we always welcome you to participate in the Match Coalition. Carrie had a question for us, which we'd love to hear. Always near and dear to my heart, the Preeclampsia Foundation. I am a proud board member of the Preeclampsia Foundation. Carrie, please pose your question.
And we love you, Fran.
Thank you.
As well as everyone else on here. And Dr. Joya, did I say that right? I hope I said that right. That was fabulous. I love what you were saying. It was more of a statement / question, I guess. The focus on the data is so important. And Fran, as you know, and many of you on this panel know, Preeclampsia Foundation has the Cuff Kit project, which I am the person that heads up. That's why I come to these meetings, because it's so pertinent, the information that you guys provide and share with us. But it's 100% about the data, because without the data, and that's why we try and push so much to collect the data. We have the national campaign going on with our phase 2 with our Cuff Kit, because the whole key is with that data. I know the blood pressure monitors we have integrated with Epic, but Epic is not everywhere. And I see that with all of the clients. I mean, a lot of them use Epic. I'm not going to lie. I get it. I understand that it is the bigger, EMR out there, but so many clients we have come in or call and say, well, we don't have Epic. And I'm like, well, there is a way to integrate, but then you have to go through A, B, C, D, and E with your IT team. And that's if your hospital approves it or your clinic approves it, or your IT team of one approves it, but the data is out there to be collected. And I think that's a huge point that we all should, definitely focus on more and more, because without that data, we can't drive home the case. The whole idea is this care for women to make sure that, we can save moms and babies alike. And that data is the proving point. That's the key to everything. So it was more of a statement, but thank you everyone. This has been an amazing meeting.
Tell Lenny, hey.
I will.
I just want to say it was an honor to be part of this, and I'm getting dirty looks in my clinic, so I have to go. Have a great day, everybody.
This has been such a fantastic discussion, and I think we all have learned so much from it. And my takeaway is to look at everything that has been discussed to see if there are ways at the federal level, because after all, this is a Hill Day, and so many of the differences between the states and the collection of data have become apparent in this conversation. And with the Momnibus is great, but are there things we could be doing beyond the Momnibus to help get more data and save more lives? So that's my biggest takeaway from this. I'm sure David and Fran are probably thinking the same thing. What can we do to encourage lawmakers to really address the needs that I've heard about today? So thank you all for this fantastic conversation. It's been terrific.
Elizabeth, and thank you to everyone. It's an amazing panel. We greatly appreciate you. We love to hear from everyone. Visit the matchcoalition.us. That is our web address. and drop us questions, suggestions for upcoming events. Next month, we will talk about AI specifically and the opportunity to apply AI. Perhaps it will be one of the another shining light on resolving some of these issues. Thank you, everyone. Have a great rest of the day.
Thank you.
Bye-bye.
Thank you. Bye-bye.